convener to one of the OSCE courses, and there were two stations we did for the OSCE course, and that's why I decided to do this. Sorry, sort of a refresher, or you can say a base of fertility for the exam going students. So it's the final step in the exam. Your knowledge is already tested in the part 1 and 2 of the theory. And OSCE is all about assessing the application of that knowledge. And for people who are doing it for the first time, it is almost like sitting in a clinic. Obviously, the time is limited and you have to get through all the questions within that time frame, and that's why I'm hoping that this will help you to get the required information. Sorry. The limiting factors in the current scenario, I think we are all aware that during your training, the focus is more on obstetrics, and that's why the gynecological exposure is quite limited. And specialized clinic access like fertility, urogyne, gyne-oncology is even more limited, which does put a dampener on getting the full sort of access to training as well as understanding the basics. So you don't need to worry, we all been there. All I want you to do is focus on your exam question, develop a structure which you are comfortable with, and follow a systematic approach to any question, not just fertility, but any station you are going to do. The systematic approach will help. And obviously, stay calm. It's easier said than done. And take a question on a face value. That's what I realized when I did those stations with the trainees, that they were trying to read beyond the question, because understand that this is an exam scenario. Everyone is there almost to help you, so no need to deviate going beyond what is provided to you. So don't read into it too much, take it on a face value, and I'm sure you will be fine. So for any clinical scenario, like anywhere, a good history is very important. And don't forget that fertility is a joint venture. It takes two to tango. So make sure that your history consists of a female history as well as male history. Obviously, it will depend on your station as well, but always remember that there are two people involved in fertility management. So don't forget the male partner. Obviously, you might given a scenarios with same-sex couple or a single person or a transgender person. So obviously, you will have to modify your approach based on the station. And it really won't matter as long as you take a systematic approach and know your basics, and you will be fine. Sorry. So in a female history, you will always start with how old the person is, have they been pregnant before, how long they have been trying to conceive for, when was their last menstrual period, how many days she bleeds, and how often. So are the periods regular or irregular? In a real life setting, if available, check their apps to get a better idea, and then also ask further questions about the period, like is the period heavy, is period painful. In real life setting, painful meaning they are using regular painkillers, hot water bottles, or taking time off work. Is there any intermenstrual or postcoital bleeding, or if there is any dyspareunia? Are their smears up to date? When was the last smear taken? Do they smoke? Do they drink alcohol? Any recreational drug use? Do they have any major medical or surgical illnesses? Are there any allergies? And is there any history of STIs in the past? In an ideal world, it shouldn't take more than a minute to go through them, and that's exactly what you will need in an exam, or even in real life clinic setting. You can actually ask all these questions in less than a minute. Obviously, once you practice, you won't miss anything. And the good thing is, if you are sitting with an actor or an actress during the exam, they would possibly have answers to all these questions, as opposed to the real life setting where you might need a lot of probing to get to the answers. For the male, it's the more or less same situation. So, how old are they? Have they fathered any pregnancies before? How long they have been trying to conceive for? Do they smoke? Do they drink alcohol? Any recreational drug use or anabolic steroids? Do they have any major medical or surgical illnesses? Are there any allergies? And if there is any history of STIs in the past? In an ideal world, it would again take more than a minute. So basically, less than 2 minutes, you would have got a full history for male as well as female. Okay, and as I mentioned again, in the exam setting, the actresses or actors will have all the answers ready. So you would probably get all the answers in that time as well. If it's a case of azoospermia or severe oligospermia, then for a male, you will ask about history of mumps, any trauma, torsion or operation to testis, if there is any history of hernia, hydrocele or varicocele, any history of testicular malignancy, as well as chemo or radiotherapy. Investigations of female partner are slightly more complex. So you need FSH, LH, and estradiol. And for these tests to be valuable and reasonable, they need to be done on day 2 to 5 of the cycle. So in real life setting, even if you have the result, always make sure that they were done at the right time. Otherwise, those values have no meaning. Anti-Mullerian hormone test, progesterone to be done on day 21. Obviously, in the real life setting, it is important to know the duration between the blood test and the period, because we call it day 21 based on an assumption that everyone has a 21-day cycle. Now, progesterone over 30 means ovulation. So if the values are extreme, like 1 or 2 or above 35, then the answer is pretty clear that they are ovulating or not ovulating. However, the problem starts when the values are borderline, like 26 or 28. And then when you ask them how many days later they got the period, then actually it might mean the blood test actually is suggesting ovulation. So, for example, if somebody's blood test was 28 and they played like 10 days after the progesterone test was taken, that means in an ideal world, the blood test should have been done 3 days later, when the value would have been over 30, indicating ovulation. Thyroid function test, prolactin, testosterone, rubella serology, and depending on which hospital you work, chlamydia swab or a serology. The female partner needs an ultrasound scan where we check the uterus, endometrium, and other pathologies such as fibroids, adenomyosis, polyps, and Mullerian anomalies. Ovaries, we check for their access for egg collection in case they end up having IVF, antral follicular count, and pathologies such as cysts. Cysts could be simple cyst, hemorrhagic cyst, endometriomas, dermoid, or neoplastic. Adnexa, you need to make sure that adnexa is clear, there are no any masses, or there are pathologies such as fimbrial or paratubal cysts or hydrosalpinx, and any other associated issues such as free fluid adhesions and rectovaginal nodules. So the scan is very important for a female partner in initial assessment as well as during the treatments. The investigations for male partner, obviously the box standard semen analysis. The current WHO criteria, the lower limits of normal for count are 15 million per ml. The motility should be about 32%. Now, depending on which lab you take, they would describe it either as a progressive or as a combination of A plus B. So motility grade A means rapid progressive, B means slow progressive, C means non-progressive, meaning the sperm is just twitching but not getting anywhere, and D is immobile. And normal forms should be 4% or more. If any parameters are abnormal, we repeat the semen analysis. Now, ideally, it is repeated after 3 months because the spermatogenesis cycle is 90 days. However, if the abnormality is severe, like if they have severe oligospermia or azoospermia, then you could repeat it in 4 weeks. If the counts are between 10 to 15 million per ml, it's called mild oligospermia. Between 5 to 10 million per ml, it's moderate oligospermia. And less than 5 million per ml, it's severe oligospermia. And if no sperms are seen, it's azoospermia. If the motility is less than 32%, it's asthenospermia. If normal forms are less than 4%, it's teratozoospermia. And there will be a clinical situation where all three parameters are abnormal. It's called OAT syndrome, which is oligoasthenoteratozoospermia. In cases of severe OAT syndrome or azoospermia, one needs to examine the male partner for presence of testis, size of the testis, consistency of the testis, presence of vas difference on either side, any scars from previous surgery, and if there is any evidence of hernia, hydrocele or varicocele or any infections. Then next course of investigation is ultrasound testis and hormone profile with LH, FSH, testosterone, prolactin, and TSH. And we also do genetic tests with karyotype, cystic fibrosis mutation, and Y chromosome microdeletion. Management of male partner will be, this is more for severe oligospermia or azoospermia that they are referred to the andrology services. Sometimes we offer them backup freeze. If they are diabetic, suffering with retrograde ejaculation, the sperm retrieval is done from urine. The lab will sort that out. Sometimes they need surgical sperm recovery, which is percutaneous epididymal sperm aspiration, which is PESA, or testicular sperm aspiration, which is TESA, or micro-TZ, where the testis is actually opened and examined under microscope for viable foci and the biopsies are taken. This procedure is done by dedicated andrology team though. There are certain good resources, nice fertility guidance. Just go through the summary, at least have some idea about your local ICB guidance in terms of eligibility for IVF, HFEA guidance, and British Fertility Society. Now, I work at Bath, so we have the lady has to be below 40, and then they are offered 3 IVF cycles. Between 40 to 42, we offer 1 IVF cycles. They both should be resident of the same area. Their GP should be same. Female BMI has to be below 30. None of them should be smoker, and if they're smoker, they have to be smoke-free for at least 3 months. The AMH has to be above 5.4, FSH has to be below 9, antral follicular count has to be 4 or more. So you can see that there are lots of criteria which need to be fulfilled before they are eligible. And that's why I said that it is better to know your basics, and you got 10 to 15 minutes per station, so you don't have to go into much detail. But once you understand the basics and follow the structured approach, I'm sure you will be absolutely fine. And all the best for your exam. If you need any other particular topic, please put in comment section and I will try and get it sorted in next few days time. All the best. Thank you.